blood pressure. You know, there are several trials, yoga exercise and other meditation that have shown to reduce blood pressure. There is impact on other habits. So you do not smoke in the daytime, so that's the positive side. You also, it may affect your exercise. However, there's no single trial to show that exercise is a problem during fasting. Actually, we should promote and encourage exercise, particularly early on the day with fasting. There is a problem in our practice of fasting because of the good habit of family gathering, but that actually changed from family gathering to overfeeding. And this is very important habit. So, you know, when we gather together, we should not really overeat. Similar to what happened in most of the conferences. You have like 5 meals and you don't move at all. However, there are differences in hypertension and fasting. And this differs from one country to another because there is difference in the time. You know, some countries fast 6 hours. You do not even feel the fasting. There are countries that fast 21 hours. There is different in the weather and season, whether it's a cold season or hot season, and the nature of work, whether you're like a professional working indoors, similar to most of us, or you are working, you know, labor working on the road in the summertime. Work regulation and working hour, and also, as I said, nature of work. And habits make a huge difference, whether you break your fast with excessive carbohydrate and salt, or you break your breakfast with you know, a dash like diet. So clinical studies, several studies, you know, I have counted more than 15 studies. At least 11 or 12 of them were mentioned in our chapter in Shams, chapter 17. They are small size. They compare blood pressure before fasting, during fasting, and after fasting. And vast majority of them would either show there is a small benefit or there is no benefit. And there's no study yet published in the literature to show that fasting is harmful. So this is a study from Turkey, and they compare intermittent fasting effect on blood pressure variability, and they have 60 patients. Blood pressure was measured in the office, home, ambulatory blood pressure, and they have seen significant drop in systolic blood pressure from 122 to 116, but that's the only parameter that improved. The other parameter did not improve. The ambulatory, the home, the you know, other reading did not really improve. And they also noticed, which is important, you know, a drop in urinary sodium. We nephrologists think that this is a very excellent, actually, you know, a parameter to look at in the dietary salt intake. Again, as you can see, that the systolic blood pressure dropped from 122 to 116. This is another study also that showed there is minor drop of systolic and diastolic from 131 to 128. We looked into this in our patient in King Faisal Specialist Hospital in kidney transplant. We probably did the largest study in the literature, around 1,000 patients. Some fasted and some did not fast. And we assessed the blood pressure, creatinine, lipid, hemoglobin A1C, weight. And as you can see, 1,011 patients, and ultimately around 280 in each arm. And we looked into all the parameters based on age, period, presence of diabetes, hypertension, baseline creatinine. In all of them, there was no difference. So the question we had, you know, the question we had, why did we get no difference? And basically because I think most of our population break their fast with very unhealthy food. No one of us resists taking luqaymat after the breakfast. Most of the diet is high in salt, high in sugar, and high in lipid. And very few of our patients break their fast with fruits and vegetables. And before I conclude the topic, I want to show you a very fascinating recent report on impact of fasting on diabetes mellitus. And this is a 3 case reports from Toronto. Age between 40 to 67, and they had diabetes mellitus type 2 for a prolonged period of time, up to 25 years. And most of them were on multiple anti-diabetic agents, insulin and oral hypoglycemic agent. And look, with fasting alone, medical supervised fasting, they were able to get rid of all anti-diabetic agents. And they could able to do this, as fast as 5 days. 5 days of fasting, and then when they break their fast, they break the fast with a medically, advised diet. So something rich in fruits, something rich in vegetable, rich in fluid, but deprived of salt, animal product, and others. And you look, they came out of their insulin, they came out of their anti-diabetic agent, and they lost weight. They have lowered their waist circumference. And this is why we're not getting the good result. So the message I want to conclude here before, an important issue is during fast, one should have adequate water intake. And الحديث النبوي الشريف ثلث لطعامك ثلث لشرابك وثلث لنفسك. And unfortunately we took probably 2/3 and a half to food and then the limited half of the third, distributed on the other things. So we do have missed opportunity, and I think we medical professionals have an opportunity to improve in diabetes, hypertension, obesity. If you go anywhere in Riyadh, in Jeddah, ask people not to eat or not to smoke, they will not, respond to you. But if you tell them fast, they will stop smoking, they will stop overeating, etc., etc. So I know it's an indirect way, but using religion and getting people health is, I think, a very smart way from us to do. So fasting does probably reduce blood pressure, weight, lipid, and glucose metabolism. And physicians should work with patients during Ramadan to achieve these goals. And this would only happen if we sit with the patient and give them a prescribed, medically supervised way of losing weight and fasting. And we should not tell patients do not fast. We should actually encourage patients to fast. During Ramadan, we should encourage patients to fast, on Monday, Thursday, or every other day. However, when they break their fast, they should break their fasting in a very supervised way. The diet rich in fruits and vegetable. With that, I conclude the fasting. And I would conclude it with what Shams, the expert, guideline, have concluded. Hypertensive patients are encouraged to seek medical advice before fasting, and majority of people can fast. Patient with uncontrolled blood pressure, they should get their blood pressure controlled before fasting. And patient education should emphasize on need to maintain compliance to medication. Patient should have adequate fluid. And once daily dose or maximum twice daily dose medication is recommended rather than Q6 and 8 hours. With that, we'll conclude the fasting chapter and we'll go to Hajj chapter. And, we know that Hajj is also a part of, Arkan al-Islam. And in Hajj, it has physical, it has emotional, and it's a very important journey in life of most of Muslims. Last year, we know that 2.4 million performed Hajj, 74% from outside the kingdom, and they have universal health insurance the minute they enter the kingdom. And this is, important effort from the Ministry of Health. Almost 500,000 outpatient visit, 43,000 emergency visit. And if we go to hypertension, the data on hypertension are really lacking. And this is a very good area for research. If you are from here or if you are interested, I think this is really a good area of research. We could see that causes of admission, you can look here that most of reason for admission have some relationship with hypertension. Whether it is in the top, cardiovascular, 63%, myocardial infarction, angina, hypertension. Most of these are either directly or indirectly related to hypertension. If we look at hypertension prevalence in people performing Hajj, it would be probably similar to hypertension in general population adult, which is around 1/3 or 1/4 to 1/3, 26%. And the journey definitely has some exhaustion, exercise, people get tired, sleep disturbed. And what we could recommend, and from this, you could see that 60 patients died because of hypertensive crisis, 30% died with cardiovascular event, and significant number underwent cardiac cath. So blood pressure control and medication adherence and monitoring are really lacking because there's no good data. What we could clearly recommend that any patient can perform Hajj, provided that they have been medically checked at least 2 months before going to Hajj. 2, they need to increase adherence and monitoring of their blood pressure and their blood pressure medication. They need to perform exercise before going to Hajj journey, because most of people get exhausted during Hajj. And if they perform exercise and training before coming, that would reduce the morbidity and mortality in Hajj. So what final message to Shams recommend? They say hypertensive pilgrims should have medical checkup before they leave home for Hajj, particularly elderly. Patients with severe hypertension should achieve blood pressure control before starting Hajj. Once daily medication regimen are preferable. Adequate fluid intake is generally recommended. Keeping blood pressure control and adherence to medication and checking blood pressure regularly would definitely reduce the morbidity during Hajj. With that, I really thank you for staying and thank you for listening.
Thank you, Dr. Hassan, for this very nice, comprehensive, evidence-based presentation and for the sticking for the time. Our next speaker, inshallah, Dr. Badr Al-Mustafa. Dr. Badr is a senior consultant, family physician and chronic care, clinical hypertensive specialist, Katifa Primary Healthcare Centers. He is the General Secretary of Saudi Hypertension Society, Middle East representative of Hypertension League. Dr. Badr.
السلام عليكم ورحمة الله وبركاته جميعا. يعني أنا أشكر وجودكم إلى الساعة هذه، وأظني رئيستنا دكتورة إيمان تقول إلى كل واحد من عندكم هدية إن شاء الله بعد ما يخلص الحلقة بإذن الله. أوكي، إلى الجميع بإذن الرحمن. نبدأ بسم الله الرحمن الرحيم. I'll be very short. The topic is for many of us, we do tell everybody just change your weight, change your lifestyle, eat less, decrease weight, but really how to? Is it really possible? Yesterday, I think that Dr. Oliver has just mentioned something that it's really difficult to decrease weight and to maintain weight reduction. Let's see. Bismillah ar-Rahman ar-Rahim. هذا لا يعمل. See, this is my town, maybe on the eastern shore of Saudi Arabia, when I have been born more than 50 years ago. However, it has dramatically changed to something like this, where everything has been changed. This is almost the same place. However, this changes didn't happen over the 50 years. It happened only during the last maybe 2 decades plus. This rapid change really make things heavy to accommodate. So how to deal with all that? See this patient. This patient has been referred to my clinic. He is just at my age. He is at my age. He was my schoolmate and was telling me why I'm being referred to you because of blood pressure was not controlled, blood sugar was not controlled at all. He is already on maximum doses almost of insulin, anti-diabetic medications, in addition to antihypertensive medications. So what else have to be done? Shall we fix it with medication as well? I've just told him, see, I'll evaluate you full, then we will talk. After the full evaluation, for 1 or 2 weeks, I've informed him, your treatment is in your hands. Nothing else I can do much. Otherwise, every other medication I'll put in your stomach will affect something else. You have to deal with it seriously. The patient took from him a few ways, a few appointments, and how to do the lifestyle change. We have just tailored out the lifestyle change, mainly. He started it seriously, and he started to lose this much. And just took from him 1 year to change to this much. His medication has been cut to 50%. His blood pressure is controlled. His sugar is not only controlled, it is over-controlled to the extent that he cut off half of the anti-diabetic medications and almost to stop the insulin. This is, I guess, the success that we all aim to, that to be free of medications and to correct the problem the way that it happened. Thanks for Dr. Hassan for elaborating much through the fasting way of dealing with the lifestyle. I think we can do it. Let's see the issue from the other way. He's my nephew. He's just 30 plus years old. He's following in a good cardiology clinic, a very busy clinic. He's a senior engineer, industrial engineer. His cardiologist told him, see, Muhammad, your weight is keeping little up, just little. And your lipids is just having little up. By the way, Muhammad is having high cardiovascular risk. His father is having premature cardiovascular disease, his mother as well, his brother as well. Okay, the next day, Muhammad planned it in the gym. He has gone to the gym. Once he is back from the plant, industrial plant, immediately to the gym, 3 or 2 hours of heavy exercise. It took from him 1 week. Thereafter, while he is in the plant, he collapsed and has been transferred to the nearest hospital where he was asystole. This is a wrong way to deliver the lifestyle message. Lifestyle, as far as it may be beneficial, lifestyle message may be so dangerous as this. Patients to exercise a lot without preparation, without to know how to prescribe exercise, may be dangerous in a highly cardiovascular risk patients. We have to be careful of that. These are one serious message we have to deliver in prescribing exercise. Let's see how to do it. Everybody has gone through all these, that the benefit of lifestyle changes are a lot. I will not go through this in details. However, we will go through how to deliver all these. Let's see ourselves. Before we advise our patients, يقول الشاعر إيش؟ لا تنهى عن خلق وتأتي مثله عار عليك إذا فعلت قبيح، ولا لا؟ إن الله لا يبغض أحدنا أن يكون يعني ليس كما يفعل. فهذا شيء ضروري أن نحن نأخذه بعين الاعتبار. So let's ask ourselves, do we do all that? ما يخرج من القلب يقع في القلب. How comes I would like to advise someone in something that I don't behave? I do eat everything, high carbs, not fasting, not drinking, drinking maybe, smoking, not doing any exercise. Really, I guess we cannot convince anybody to do any change. So we have to change it. We have to do that. This is the message number 2. We do see many facts that the activity will do a lot. And there we have many of the evidences for so. So we have to believe in that. We have to know, to have some background about these evidences and how to change all these. What is the changing physiology in our body, whether we are kids or adult? We are having changing physiology, and the exercise will be changed, the exercise message, depending on whether I am a child, growing child, an adult, or elderly. So we have to have some background, and this is science, not just advices. One more issue, that we need to go through these and believe in them in much. We have even that 1 minute or just 10-second advice for tobacco quitting will increase the percentage of tobacco and smoking quit in a year time. So we have to believe in that in serious. The advices, are they just one way? No, we have many ways to do these advices, but we have to learn them. As far we have learned how to deliver, prescribe, we need to know how some of the pharmacokinetics, some of the pharmacodynamics. We need to know as well the behavior of the patients, the behavior of the human being. How do they really behave and how they can change their behavior? Really, this is a difficult issue. Just yesterday, Dr. Oliver thankfully has told one thing, that being a pharmacist, I haven't studied 1 hour of psychology at all. So how can I affect my patients? And we have to practice it much. There are many barriers, but believe it. من تردد على شيء أوتي حكمته. يعني we need to do it gradually, one by one. Not just to throw it away and I'll be a good behavioral changing man. I have to practice it one by one. These are many of the guidelines which have been tailored out to deliver messages and to change behavior. These ones have been settled by many of the societies for changing behavior. We need to follow them. So as far as there are guidelines to treat high blood pressure, there are guidelines to change behavior. We need to go through these guidelines. يعني بالعربي يحتاج دورة الواحد ياخذها to change behave. بس ما معناه ينتظر الدورة لحد ما يسويها. ولكن we shall do such like these issues afterwards. Let's be one of our aims to have it. I need to skip many of that for your sake, and I'll conclude here. Yes. We have the number one, is my patient ready to change or not? To ask myself. If he is not ready, please don't try to change. Don't try to prescribe any change. Just make the effort hard to make my patient ready. And after that, after maybe 1 month, 2 months, 6 months, think about how to change his behavior after becoming ready for the change. And this may take a lot. Let me conclude here. This is not working. Yeah. There are many tools we can use. These all are brochures, pamphlets, follow-up encounter forms that may be used for that. Yesterday, our colleagues have presented and handled a workshop in lifestyle management. It is an introduction in how to change that. It was well presented yesterday. All these are encounter forms which I can use. And as you can see, that there are methods, tools to be used. This is my last slide, maybe. For changing behavior, we have stages. And these stages, we have to go through one by one. We cannot go through pre-contemplation. واحد ما مستعد أصلا. غافل ما يعرف ولا شيء. فإذا أول مرحلة حتكون إيش? The first step is to bring him to contemplation. ومن بعد ذلك بعد الغفلة والوعي, once it's gone, then I'll go to the other steps. And these steps needs not to go directly for action, but we need to prepare. This is ABC psychology. This is ABC of behavioral changing. We don't need really to recreate the behavior change methods from our own. We have to follow guidelines for that. And this is my message, really. We need to follow guidelines for changing behavior of our patients. Thanks a lot.
Thank you, Dr. Badr. Thank you, Dr. Badr, for, as usual, very practical, very interactive, and direct from real life, from experience. Our next speaker will be Dr. Nawal Al-Basri. Dr. Nawal is a senior consultant nephrologist, National Guard Health Service, Al-Madina Al-Munawwara. As you see, Shams is really, our nephrologists are predominant in our society. So I am greeting them. Dr. Nawal. He will talk about chronic and hypertension and chronic kidney diseases. It is a heavy subject. Please pay attention.
It is a heavy one. Yes. Okay. Bye. Assalamu alaikum wa rahmatullahi wa barakatuh. I'm really happy to see you are still here and you are still awake. Hopefully that you will continue awake after I finish my talk. My talk's supposed to be this morning, the first lecture, and move down to the last lecture today because of the changes we've done in the schedule. I'm going to talk to you about hypertension and the kidney. Now, hypertension and the kidney is Okay. Hypertension and the kidney is a big topic, but I'm trying to make it short and easy for you. So I'm going to skip a lot of my slides. These are the outlines of my talk. After the introduction, I'm going to talk to you about chronic kidney disease, then about hypertension and the kidney, and then at last, hypertension and renovascular disease. So chronic non-communicable diseases have become now the leading threats to public health and health budgets worldwide. Death attributable to infectious disease declined significantly to 3% and going to decline further, while death according to chronic illnesses will increase and is increasing. Hypertension is a worldwide public health problem, and chronic kidney disease is also a worldwide public health problem. Hypertension is the most frequent complication of chronic kidney disease. Chronic kidney disease is a common and underappreciated cause of resistant hypertension. That prompted the International Society of Nephrology and the Federation of Nephrology to devote World Kidney Day in 2009 to hypertension. And the message that year was hypertension and chronic kidney disease emerge that should not happen or should be prevented. So chronic kidney disease, it took us as nephrologists a decade to reach to this definition. And the definition of chronic kidney disease is defined as an abnormality in kidney function for more than 3 months, according to kidney markers. And just in short, a GFR means glomerular filtration rate less than 60 milliliter per minute per 1.73. As 5 stages from 1 to 5 according to glomerular filtration rate, and if according to stage according to proteinuria, A1 to A3 according to the presence of proteinuria. Now, why it is important? Chronic kidney disease is significantly important because all cause mortality, and especially cardiovascular mortality, increased with the reduction of GFR below 60. The more red, the more goes with more mortality, more risk goes with more proteinuria and decreased GFR. So the epidemiology, CKD is a global crisis affecting 10% of the global population and responsible for around 1 million deaths per year. In the United States, that's around 30 million people are affected with CKD. That makes 15% of the total population. Globally, CKD affects 1 in every 5 men and 1 in every 4 women above the age of 65. And those above the age of 75, half of them are having risk of CKD. This is global prevalence. And this is in Africa. The prevalence range from 4% to 16.5%. That's in Europe, the stage 1 to 5, between 8 to 21%. And if we look further to stage 3 to 5, it's 3 to 10%. So 1 in every 3rd adult are at risk of CKD. This is the latest prevalence in the United States of 2016. The crude prevalence of CKD stages 1 to 4 is around 35%, while if we look to the stage prevalence according to age and sex, it is around 15.5%. The same the same information or same prevalence in 2014. Okay. China also, it ranged from 10 to 18%. And now, if we look at end-stage renal disease, globally, it is high incidence and high prevalence. The incidence differs in different countries. The 2016 incidence of untreated end-stage renal disease differs in different countries. Saudi Arabia, it is 145 per million population. and the prevalence of, in Saudi Arabia, 826 per million population. Now, epidemiological studies of chronic kidney disease in Saudi Arabia, we've got very little epidemiological study. Dr. Abdul Karim Al-Suwaid, our colleague from Riyadh, he did that pilot study, and he reached the overall prevalence of CKD was 5.7% to 5.3% using different equations. A significantly higher prevalence of CKD, around 25% in those above 60 years. Another more recent study, that's Abdul Karim, also found that a high prevalence of CKD in hypertensive subjects. So 58% of hypertensive subjects have got CKD. This study is a very recent one, published only last month. That's also done in Riyadh, 4 different hospitals. They looked at more than 700 hypertensive patients looking at CKD. And the hypertension duration in those patients, they are hypertensive for 4 years. And they found that overall prevalence was 46.9%. So hypertension and chronic kidney disease. The prevalence of hypertension in CKD patients differs according to the kidney problem. And it goes down as low as 10% in some minimal change disease patients and as high as 85% in focal glomerulosclerosis or adult polycystic kidney disease. So CKD prevalence by hypertension, if we look at that, around 35% of patients. Now, CKD patients having hypertension, and let's look at the other side of the coin. Those are CKD patients, how many percent of them having hypertension? Up to 85%. In the United States in 2014, we have the same, more or less same prevalence of hypertension in CKD patients, especially in end-stage renal disease patients, and especially in those above the age of 75. It's more common in Black than white and Hispanics. So hypertension here, second most common cause of end-stage renal disease. This is common in white, in Black, and in Hispanics. Let's look at Saudi Arabia. The end of 2016, this is the annual report from Scott Saudi Center for Organ Transplantation. These are hemodialysis report. By the end of 2016, more than 16,000 patients are treated with hemodialysis in Saudi, and with an annual net increase 6.2%. Hypertension was found to be the second most common cause of end-stage renal disease in Saudi Arabia, account for 38%. Both goes together, hypertension and diabetes. It is present in 35% of those patients. And the trend of both are increasing in Saudi Arabia as well as in worldwide. So in the United States Medicare data of 2013, they found that they looked at CKD patients, how many of them having hypertension as comorbidity, and up to 92% of those patients having hypertension. So there is a connection between the kidney and the blood pressure control. This is not a new connection. We know about this information more than 200 years. In 1836, Bright have described that abnormalities in urine production by the kidney will increase vascular resistance and lead to high blood pressure and increase cardiac mass. A century later, Goldplate, our famous Goldplate model, he obstructed one renal artery and induced malignant hypertension. The famous Guyton in 1972 described that the kidney, or his hypothesis, kidney governs the level of blood pressure by regulating extracellular fluid volume. And if the blood pressure increase, then the renal perfusion increase, then a consequent sodium and water excretion increase, what they called as pressure natriuresis. So these are some of the selected factors for pathogenesis of hypertension in CKD. Impaired sodium excretion, activation of renal angiotensin system, sympathetic activation, imbalance in prostaglandin or kinin, endothelin, reduced nitric oxide. And in end-stage renal disease patients, all these mentioned factors, added to them some more factors. the use of erythropoietin, and hyperparathyroidism, anemia, and arteriovenous fistula. I will skip all these slides. These are the pathogenesis of hypertension and what happens inside the kidney vasculature, because these all have been mentioned by Professor Sami Sanjad yesterday. Role of salt. Some of them have been mentioned this morning. There are immune and inflammatory changes, and nitric oxide, oxidative stress, endothelial dysfunction. Now, if you are interested actually in the pathogenesis of renin-angiotensin aldosterone system and the pathogenesis of the effect in this is an excellent review article I found, and it's a bit heavy article, but this is a very excellent article. The inextricable role of the kidney in hypertension. The title of this article was very nice. Inextricable بالعربي معناها إيه؟ معقد لا يمكن الفصل بينهما. أو مستحيل الفصل بينهما. Inseparable. So I'd skip that. Very nice article. Okay. Now, hypertension, a cause and a consequence of CKD. It is both. الدجاجة قبل البيضة ولا البيضة قبل الدجاجة. So, hypertension as a risk factor for CKD. This is the pathophysiology. At least two pathways. Hypertension stimulates glomerular ischemia following damage to preglomerular arteries and arterioles. This leads to progressive luminal narrowing and reduction in glomerular blood flow. Additionally, post-glomerular renal ischemia occurs, contributing to progressive loss of nephrons. The other pathway is chronic hypertension contributes to loss of autoregulation of afferent arterioles. Transmission as high blood pressure leads to hyperperfusion, hyperfiltration, and progressive loss. Now, hypertension as a consequence. If we look at hypertension as a consequence of CKD, all these factors have mentioned in the pathogenesis. I will skip this. We ended up by nephrosclerosis. So what is the impact of hypertension in CKD patients? It increased hospitalization. Hypertension was found to be one of the top 10 causes of admission to hospital in end-stage renal disease. It will lead to progressive renal loss. And these are the studies, very famous IDENT studies, very famous studies showing that hypertension contributes to progressive loss of kidney function. What should be the target? There is little evidence among patients with CKD that a goal of below 130/80 saves lives, saves kidneys, or reduces cardiovascular events. Nonetheless, blood pressure control is important, and therefore, as in general population, blood pressure should be targeted to less than 140/90. We've got many studies about the target of blood pressure, MDRD. There is usual blood pressure control, and there is intensive blood pressure control, the REN2 and the ASK study. Now, what pharmacological agents? All these agents can be used. Look at the top here, ACE or ARBs. ACE and ARBs, these are studies which showed that ACE and ARBs are very beneficial in hypertension control in CKD patients. So combination therapy, most of those patients need more than one medicine, and we can combine ACE or ARBs with calcium channel blocker, with thiazide diuretic, but we should not combine both together.
5 minutes.
Okay. Now, the KDUKI guidelines, this in 2012, this is the most comprehensive one looking at management of hypertension in CKD patients. As my colleagues have mentioned, lifestyle modification. I just want to stress here that low salt intake is very important in those patients. Okay? Now, quit smoking, exercise, but we should not hear, we just take a note that we should not hear, we cannot recommend potassium supplementation or magnesium supplementation in those CKD patients. So the blood pressure control in non-diabetic, non-dialysis patients, this is an algorithm of summary of KDUKI actually, according to urine albumin excretion. If urine albumin excretion less than 30 milligram per 24 hours, we use our goal is below 140/90. If it is between 30 to above 300 milligram per 24 hours, our goal is below 130/80. Now, if in diabetic, because usually those two goes together, diabetes and hypertension and CKD. So if urine albumin is below 30, the aim is below 140/90. If above 30 milligram per 24 hours, below 130/80. And this is a transplant patient. Transplant patients, we aim at below 130/80, and we choose the antihypertensive medication depending on the GFR. Dialysis patients, very important, and I want to stress on this message. Dialysis patients, we need to control the dry weight, usually volume related. And then we use antihypertensive according to the compelling indications. Okay, now JNC8 recommend that below 140/90, ACE or ARBs can be used in CKD patients. The latest Canadian guidelines recommend below 140/90, and according to proteinuria, thiazide can be used in early stages of CKD, while loop diuretic in late stages. SHAMS guidelines in treating CKD hypertensive patients. We made it very simple, very conclusive actually, and the aim here of below 140/90 in CKD without proteinuria. If CKD with proteinuria below 130/80, you will find this in our guidelines. What to use? Again, we make it very simple, ACE or ARBs, and that's in CKD patients. Okay, now renovascular hypertension. Again, we've got a chapter about renovascular hypertension in our guidelines. So this is our chapter, and atherosclerotic aortoarthritis, fibromuscular dysplasia, aneurysm, all these causes of renovascular hypertension. This is an example of atherosclerotic one, and this is a CT scan of atherosclerotic renal artery stenosis, and again, this is atherosclerotic aorta with atherosclerotic renal artery. Fibromuscular dysplasia, what it looks like beads, and this is again a CT angiogram. Now, aneurysm, renal artery aneurysm can compress on the other part of the renal artery, causing this renovascular hypertension. This is the pathogenesis. Now, renovascular disease is suspected in the following clinical situations. This is in our guidelines. Probably you can refer to our guidelines and you will see these. When do we suspect this? In these situations: sudden onset of worsening of hypertension, age of diagnosis above 55 or below 30, presence of abdominal bruit, hypertension resistant to 3 or more medications, a rise in serum creatinine level of more than 30 milligram after the use of RAS. And what to do then? We do captopril enhanced radioisotope if the GFR is above 60 milliliter per minute, magnetic resonance angiogram, CT angiography. And this is the same here. These are the symptoms and signs. And what we do is, these are in our guidelines. The recommendation here of assessment in the Canadian of 2000 guidelines of 2018, the same as our guidelines, the way of assessment. Okay, recommendation on the treatment. Patients with hypertension affected to atherosclerotic renal artery disease should be managed medically primarily. Okay, we have to make caution that use of SORs in those patients. Renal artery angioplasty and stenting for atherosclerotic hemodynamically significant renal artery stenosis could be considered in the following situations. This is fibromuscular dysplasia after angioplasty, and that's atherosclerotic after stenting. Another one here, and this is another one. This is a repair of renal artery stenosis. So in conclusion, ladies and gentlemen, hypertension is the most frequent complication of chronic kidney disease. Chronic kidney disease is a common and underappreciated medical cause of resistant hypertension. Thank you.
Thank you. Thank you, Dr. Nawal, for this nice presentation. And we apologize for shifting your presentation at the end of the day rather than in the morning. I invite Dr. Nawal, Dr. Badr, Dr. Hassan to the stage for receiving comments and questions. So, So, any question, comments? So, I have a question, Dr. Badr, because you touched the area of my interest, lifestyle modification. So, from your experience, how many of your patients did respond to your advice regarding lifestyle interventions? You could not hear me? Okay. Did you? I'm asking the percentage of your patient which respond significantly to your lifestyle, your advice for lifestyle modification intervention.
It's really amazing. I guess many of us have recall this scenario that one of your patients may come to you one day. He will tell you, "Doctor, do you recall that you told me while you are in a hurry a little message? From that time, I have stopped doing so and so, and I have started to do and so and so." It took from us maybe a fraction of just a few seconds. However, it was very effective. Maybe because that patient was willing to change, ready to change, aware about the change, and he is aware how to change. He needs only to be pushed and directed to the way. I guess we need to do it. Many of our patients will respond really, but how far we do follow the right way of doing the change. If we are failing to do it right, I guess more likely we will fail to get it right at the end. If personally I did it right, I would say most of my cases will succeed.
Great.
But how many of the times I do succeeding in doing it right, I need to study myself.
Okay.
Hello. Thank you very much. If there is a patient with one kidney only, and people always advise him to drink a lot of water, is this good advice or is worsening the kidney more?
Now, if a person discovered incidentally that he's having one kidney and he's living normally without anything, just discovered incidentally, it means that this kidney has been there either from disease or congenitally atrophic, congenitally no development of the other kidney. This kidney usually is undergoing hyperfiltration, and to keep that kidney going on without any problem, we have to continue keeping that kidney healthy, avoiding all insults, including, of course, dehydration. So advice is good that we advise him as normal to have lots of water. And this advice we tell ourselves and everybody else that we should really not to forget keeping ourselves as hydrated as possible, especially in hot weather. Drinking water, drinking water, drinking water, yes.
Any other question, comment? Dr. Nawal, Dr. Badr, from our observation I think all Shams members noticed, and all specialty, that most of our patients having hypertension with cardiometabolic risk factors end up on dialysis, end up in open heart surgery or severe retinopathy in spite of the hugest global health budget, Saudi Arabia. We have many specialties, subspecialty, we have hospital, health centers, we have everything. I'm just throwing the question why we have this disastrous project of hypertension and other cardiometabolic risk factor. Do we need them to end in hemodialysis and open heart surgery? And why?
I guess we need all. We need to have primary prevention, secondary prevention, and as well tertiary prevention. We cannot really depend on just one type of prevention to decrease the epidemiology of this huge problem. Unfortunately, the primary prevention is very costly, not in terms only of money. In money, it is much more cost effective than the others, but it is costly because of the way to do it is not just straightforward, and there is nobody to sponsor it from the industry. The industry are marketing, and this is the whole notions. We are consumers all over the world, and one of the products that we are consuming is what the industry, whether they are pharmaceuticals, machines, devices, and so. But for primary prevention, unfortunately, nobody maybe is marketing that.
Okay.
I do agree with Dr. Badr.
Yeah. Could we bring the mic?
السلام عليكم.
Okay, go ahead.
دكتور سام الزهراني جي بي. أنا دكتور سام الزهراني جي بي من الرياض. طبعا أنا جاي هنا على أساس الموضوع من وزارة الصحة وجانا إلكترونيا، فقلت يعني آجي هنا على طول وأحضر المحاضرة، أحضر المؤتمر هذا اللي هو بخصوص الهايبرتنشن اللي هو مهم جدا يعني خاصة في الكونتري and worldwide. My question is very simple. I'm as a general practitioner. When a patient comes to me with 140 or 160/90 or mild hypertension or hypertension stage 1, how could I give him or what is the best medication or first line medication to give? Because it says here give angiotensin converting enzyme inhibitor. So which one should I choose, or based on what milligram, or based on يعني I'm a little meticulous about how to choose it, the medication.
Medication. If we understood your question right, you are asking, you are just hypertensive, and which medication to start with?
Yes.
Is this the question?
Yes.
You know, the first medication to start with is lifestyle modification.
Yes.
And we should liberally prescribe exercise, diet, and life change, and observe the patient for probably 3 months. If that is followed and not successful yet to control blood pressure, then you can use any of the 4 classes of medication as Shams guidelines said. You could use calcium channel blocker like amlodipine or others, or ACE inhibitor, angiotensin receptor blocker, or diuretics. And any of them have equally sufficient evidence that they reduce the blood pressure and they prevent organ damage.
So there's no first stage, second stage. I'm free to choose. Thank you very much.
Just little as far you are a GP, there is one little thing we need to put an eye on, which is the facilities to follow patient. If I'm having no facilities to follow the patient or to assess as well before starting the medications, it may be unwise to go for those medications where I need to do a renal function afterwards, such as diuretics or ACE or ARBs. However, maybe the only medication left with me to deal with it are the CCB classes, where I don't need really to have a precaution in most of the cases to do a renal function test. This is an issue I do face in many places where I do train physicians and GPs. They will tell me, see, we don't have renal function to do easily and to have the results early. I would tell, so what medication to choose? I'll tell you, then go for a small dose of amlodipine if available. Dr. Uthman. Still, we do have it, unfortunately, in our country.
There are 3 nephrologists here who say you do not need to check renal function when you start ACE or ARB. The 3 of them are myself, Dr. Nawal, and Dr. Fureh, and Dr. Saleh. So like 4 nephrologists say you don't need to bother about the renal profile. You can do it safely, effectively, and it's clear that if you are highly suspicious for renal artery stenosis, then you need to check for the potassium and the rising creatinine. But in form of magnitude, this is extremely rare. You're talking about less than 1 in 1,000. So at least, whether you consider it evidence or opinion, the 4 nephrologists would say, at least the 3 of them are outstanding nephrologists would say you do not need to test.
Thank you very much. We have just small certificate and present to our eminent speaker, Dr. Nawal. Dr. Hassan Al-Eid. مصطفى.
شكرا. لا
Take over.
I really thank all of you, especially the audience who made the real success. I really thank you very much for sitting until this time. Maybe you need a massage for your back. And I would like to thank all speakers for excellent presentations and thorough, and shedding the lights and to be on point and time. And I would like to thank the organizers and organizing committee and the best people. I would like to thank our volunteers from King Abdulaziz, Rabigh. Thank you very much. You made the success. Thank you. You please come. Thank you. And from Al-Imam Abdul Rahman University, one volunteer, I really thank you also. Please come. يعني Ahmed is the leader of the group. He leads the success, and inshallah he will be very successful surgeon later on, and very successful in event management. He is real leader. Thank you, Ahmed.
الكاميرا وراكي.
تعالوا.